ערב טוב כולם. שמי מרי רודולף, אני פרופסור לבריאות הציבור בפקולטה לרפואה חדשה בצפת. ואני מקווה שזה לא הפתעה, אבל אני ארצה באנגלית. אני כן מדברת עברית, אני כן מבינה, אז אני חושבת שזה יהיה דו-שיחי. אז תשאלו שאלות בעברית אם זה יותר נוח, אבל אני חושבת יהיה יותר טוב אם אני מרצה באנגלית. So, I'd like to start with telling you a bit about my background. I'm a pediatrician. I trained in the States and in England and worked here for a while, and then left the country 25 years ago and came back just 18 months ago to work in the new medical school in Sfat. And that's why my indulgence is that I'm going to speak in English. It's still not yet comfortable speaking in Hebrew. So, my interest in infant growth started when I was at Yale years and years and years ago. I did a fellowship in endocrinology. And after a long period of time, I came back to England, where I worked in the community as a pediatrician. But I really developed my interest in infant growth from that point on. And what I want to do is to tell you a bit today about the research and the approach that I used in working with children with failure to thrive in England. And then we'll come on to some of the more practical aspects, and hopefully there may be something you can learn, we'll see. We'll have a break, and then we'll come back and we'll look at some videos of children eating and work together to see what sort of advice can be given and help can be given to families. So, first of all, we'll come on to talking about what is failure to thrive and what is weight faltering. But what is clear, it's a very common problem. It's also very complex. It presents in all sorts of ways, in its presentation, in its causes, and the effect it has on a child. The presentation can vary. It can be very mild, but it can also be fatal. And lastly, and I think the most important thing for me, is that often weight faltering is an indicator of other concerns in the family. And that's what I really want to focus on today. Okay, so let me tell you a bit about the work I did in England. I set up a team because in order to work in this complex area, it was clear that the best way of working, probably in any area, the best way of working is in a team. And I drew together an achot tipat chalav, we call them health visitors, a dietitian, had a little bit of time from a social worker and a psychologist. And the sort of problems that we dealt with were billed as failure to thrive and weight faltering. But in essence, what we were really doing was focusing very strongly on eating difficulties, the effect of having a child who's not growing well on the family, and the parental stress and anxiety. And this was the bulk of what we were doing, but there was also some children we were seeing who'd been given enteral feeds, and we helped to wean them off the tube and to be eating properly. So the big emphasis was on tackling eating difficulties and helping families have a good feeding interaction. So the approach we took was that we worked very much in partnership with parents around their concerns. And I can't emphasize that enough. I think too often we tell families what to do, but our focus was to work with them and really address what their concerns were, not just our concerns. An important part of this, as you will see from the last session, is visits to the home. And I don't believe that happens very often in Israel. But occasionally, would achot tipat chalav, she wouldn't. Okay. 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 I mean, the thing is that you can learn so much from seeing a child in the home. And most of it was one-on-one work, but when things were very complex, when there were serious worries, then the whole team would work together with the family. I think what drove our work was what we were hearing when we had a relationship with families about what they were receiving before they came to see us. And this is something that I think is seriously worrying. And from what I hear here, I'm not working clinically here, but this is not uncommon in Tipat Chalav. Here are some comments we had from parents in some qualitative research we did, and I'll read them out. So it was a problem made worse by the professionals saying, he's not eating enough. You've got to make her eat more. And that's the general message. When you see a baby failing in weight, you say, give them more to eat. The desperation of parents is that you can offer it to the child, you can't make them eat. I don't think the health visitor, the Achot Tipat Chalav, was that interested. She said his weight was okay, so she weren't that bothered. So this was the other side, where this was a mother who was very concerned, and yet the health visitor wasn't responding in a way that was helpful. Both me and my husband felt we were to blame. We felt guilty. They made you feel like that, as if we were somehow starving her, which we weren't. The paediatrician said, there is nothing physically wrong, so get more calories into him. And that was that. There was nothing else that they advised us. Everybody gives you a different advice. And then you don't know who's to follow again, you see. So the messages coming across is either we're very simple and we say just give the food, or we say don't worry, it's a normal small baby, but we're not really addressing the parental concerns. So we developed an approach, and it was based on these 6 aspects of work that we did and drew on from others. The first, which I think was the light bulb moment, was when I read of Maria Ramsey. I mean, we're going back a long time now to the early 1990s. But she wrote about a transactional developmental model. So failure to thrive wasn't just that not enough calories were getting into the baby. There was something going on in the relationship between the mother, the carer, and the baby. And this was the transaction, the interaction at a mealtime. And the developmental side was, of course, that it depended on the stage of the development of the child as to where they were at. So she framed a way of looking at babies and young children with failure to thrive that was looking at the interaction and the developmental stage of the child. I was very taken with this approach, and I managed to get a small amount of funding to do a randomized controlled trial once I started working, and I will show you some results of that. But the essence of it there was that we had a health visitor, a nurse, whose job was to go in and support the families in whatever way she could. And we did it as a randomized controlled trial because we wanted to see how helpful was it for home visiting to occur and to work in this way of working to help babies do better in whether it was growth or development or behaviour. We very carefully ordered our work. We looked over the years, we monitored every child we saw and we collected outcomes on them. We carried out some qualitative research, and I showed you some results of that now. We contributed to an important piece of work by the Children's Society in England, which was trying to look at what failure to thrive was about. How should we be working with these families? And the work of this will be very important when I show you a slide shortly. And then lastly, and very importantly, I was very interested to know how these babies do. And so I carried out a systematic review from the literature to see what the prognosis was for babies who failed to thrive. First of all, the randomized controlled trial. Simply, Pauline, my nurse, the trial included every child that I saw in my failure to thrive clinic. The families were randomized with their consent to either just seeing me in the clinic or seeing Pauline at home as well. And what we were interested in at the end of the day was how the children grew. We had a measure for maternal anxiety. We looked at resources that we were using, who was seeing the child, whether they were admitted to hospital, what was going on there, and then lastly the qualitative research. And I could talk for an hour about that trial, but I think the important thing was that the growth didn't differ very much between those people who were seeing me once every 2-3 months and those who were seeing Pauline initially every week at home and then gradually turning it off. So that was interesting. They actually all grew. The big difference was in eating difficulties. And I can't see what I've written there. But anyway, there was a huge improvement in eating difficulties between the two groups and over time. Both improved, but the ones who were getting Pauline's care improved much more. What she was really doing was managing to solve those difficult eating problems that young children who don't grow well often have. So, before I go on to that, what I was really interested to hear, that's just a bit of background about my work and my approach, but I wanted to know if you had thoughts about what we could be discussing today, if there was any particular questions you had, so I can write them on the board and then see if we can answer them as we go along, and certainly check at the end whether we've got through everything. Was there anybody come with any particular questions, thoughts, needs?
What is the best advice?
Okay. הייתי צריכה לכתוב בעברית אולי, אבל... Okay.
What is the worst advice?
Okay.
When you have to
Have to do with the parents.
when do you interfere?
Okay.
What are the red flags?
The red... okay.
When
Sure.
you send to specialized clinics, because we have
Okay.
FTT clinics in almost all hospitals in the area.
Okay. אפשר לשאול בעברית, זה בסדר.
When they complain of my child is not eating pathological and it's switching.
Is that a question? What? אז מה לעשות?
לא, מתי כשהורה אומר, הילד שלי לא אוכל, מתי זה באמת בעיה.
אפשר להגיד ש- when is picky eating ממש בעיה. כי המספרים באנגליה זה 1 בכל 4 ילדים יש בעיה באכילה, אז מתי זה ממש בעיה?
איך מכניסים את זה ללוח זמנים סביר, את השאלות האלה?
איך מכניסים
ללוח, ל5 דקות. לא 5 דקות, אבל ברבע שעה זמן אפשר בתור רופא ילדים לגשת.
כן.
How to do follow-up? You decide that there is a problem that you think you can handle yourself.
Yeah.
What is the proper follow-up?
Okay.
When do you ask the parents to come back?
כמה להעמיק ברור פיזיולוגי? בכל זאת יש כמה... מתי
אה.
אתה אומר, אוקיי, זה פיזיולוגי, זה לא פיזיולוגי?
So, מתי לדאוג על הפתולוגיה?
לעשות אם אנחנו חושבים שזה פתולוגיה?
Okay.
What is the prognosis for untreated?
What is the prognosis for?
Untreated, unintervention.
That's a difficult one. Okay.
Of untreated.
כן, אבל יש מחקר. אז סך הכל זה ה-systematic review שעשיתי בעיקר, זה מה ש... It's difficult, but... מספיק?
ההגדרה של הבתי היום, שעדיין היא לא באמת מובנת, עכשיו הרבה ילדים בעצם מופנים אלינו מטיפת חלב כי האחות נזעקת שהילד ירד בעקומות ובעצם
כן.
יש לו הורים קטנים והילד מפותח מדהים ואתה לא רוצה אפילו לדעת בו, הוא כל כך עמוד, אבל הוא ירד באמת מהחוזון 75 אפילו ל-25 או 10
כן.
צריך גם להגדיר מחדש מתי הבעיות, כי...
כן, ואיך, זה מרכזי, כי אני חושבת, דואגים שאנחנו עושים יותר נזק, כאשר אומרים שיש בעיה פה.
יש לנו בפריפריה, ולא נזלזל שלא כולם מגיעים למערכת בריאות שווה, אבל בסך הכל יש נגישות וזמינות, כלומר, הילדים שאנחנו רואים באמת חולים או שיש להם מחלת רקע, אני לשמחתי, אין לי ניסיון הרבה בנגלקט או בקשיי האכלה יותר מדי, כי אני עובדת במרכז הארץ, אז לא נתקלתי באמת באנשים שלא קיבלו מענה מהר. הרי תוך שבועיים, אם ילד לא עולה במשקל, ישר הוא מופנה בהבחנת FTT זועקת. זה שלא בכלל מה ההגדרה ומה הדברים שאנחנו בכלל מטפלים בהם, כי המסה שאני נתקלת בהם זה באמת כלום, ואחר כך אני צריכה להשקיע את כל הרבע שעה ביקור בלהסביר לאמא שהכל בסדר, ואנחנו נעקוב אחרי הילד שלה ונראה שהוא גדל ומתפתח יפה, והילד בגיל חצי שנה כבר עומד והוא פשוט קטן.
כן.
ההגדרה הזאת היא נורא בעייתית.
זה מאוד, כן. אני איתך, ומה שאני דואגת, שזה לא סתם בזבוז זמן של אנשים, זה גורם לנזק בתוך המשפחה והחרדה.
גם שבאמת לא נדקור סתם ילד על ירידת עקומות, על בירור 10,000, ונראה שהוויטמין D שלו בסדר, שבסך הכל בסדר גמור הילד.
אני חושבת שמאוד חשוב על איזה גיל אנחנו מדברים.
באיזה גיל?
איזה גיל, על איזה תקופה.
אז זו שאלה לכתוב פה או...
אני חושבת שזה מאוד משנה, הגישה לא תהיה אותו דבר אצל ילד
אוקיי.
4 חודשים, אישה או...
אוקיי. 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 אוקיי, נראה אם אנחנו יכולים לענות על כל השאלות. Okay, so I'm delighted to hear it because actually what I was seeing was that what we needed to look at was the definition and causes, what our role is as paediatricians as compared to anyone else, a big focus on assessment, but particularly the dietary nutritional history and meal times, a bit on management, prognosis, and then the second part, as I said, would have actually looking at meal times, which will help. In discussing it, I think we'll answer some of the questions about what can we do. And the panel discussion, I understand, has been cancelled. Okay. So why are we so concerned about failure to thrive? I mean, it's something that we generally, or the public, nurses, are extremely concerned about. What is it that concerns us when a baby doesn't gain weight well? We like, okay, absolutely. Okay, so you're saying there's something cultural. ואין משהו יותר מרכזי מאמא לתת אוכל Okay.
And it reflects on the mother. If the baby gains weight, then she's doing a good job.
Yeah.
If the baby is not gaining weight,
Then she's okay.
Especially the first time mothers are very concerned that the baby is not gaining as much weight as they would like.
Right. Absolutely. Anything else? What about
If there is an underlying disease,
Okay.
course, seriously something to worry about. Failure to thrive could be the first time.
Yeah. Okay.
The first 2 years are very crucial for the brain development, so we're worried
So we're extremely
that he might lose something in his potential to be
Yeah.
genius or whatever. So
Which is, comes to your what's the prognosis with without treatment.
ילד כזה נתפס כילד חולה.
Oh,
שכיבי,
חולה? מי מדבר?
ילד הזה נתפס כילד חולה.
חולה קטן.
Okay, so this is interesting.
כמוני.
What, anything else?
כי לשכנה הילד יותר גדול ושמן וזה מאוד מפריע, ולסבתא במיוחד.
Okay.
לאבא לא אכפת, אבל נשים...
Is there something else professionally that worries you if a baby fails to thrive? No. You're missing an illness. Okay, anything else? Okay, you're worried שיכול להשפיע על ההתפתחות אם הוא לא אוכל בסדר.
זה איזושהי פונקציה בסיסית שילד צריך לעשות.
Okay, gosh, this is really interesting. Okay, I mean, what I've got up, which we've talked about, is...
Psychological relation within a family.
Yeah, no, absolutely. What you haven't mentioned, I mean, I've written these things which you've just all mentioned, but in England, I have to tell you that the big anxiety still, I think, but certainly a few years ago, was the issue of child neglect. How much is this a sign of neglect? And maybe this is something completely culturally different here. Let me tell you the story of this little girl that caused an absolute media and professional crisis. It's a little girl called Jasmine. Here you can see, here she is gaining weight after birth. This is years along here, okay? She started falling off here and was brought into hospital here because she had a fractured femur. And she was discharged from hospital here and she went into foster care because they were so worried about the family. And you can see she's been followed by Tipat Chalav very nicely. She's gaining weight beautifully, just as happens when you have child neglect. And then she went home on trial. And guess what happens? No, wait a minute. No, the family didn't take her to Tipat Chalav. The nurses never went to find her. So there were no weights until, this mashed area is just nothing, okay? And there was no weights done until she was brought in dead into the emergency room at the age of almost 5. And that, I mean, you can imagine, you know, the neglect of the services not to follow this child was awful. And I think that's something that really underpins the way that doctors and nurses work in England, which I wanted to dispel, but it's very, very interesting that it doesn't seem such an issue here. Israel...
The population we deal with is different. It depends where you work.
I think, listen, it can happen anywhere, but Israel is a much more child-loving country, and I think maybe, hopefully, this thing sort of... Okay, so...
I had a mother in Tipat Chalav that didn't want, the baby was a year old, and she didn't want to give him solid foods because the kaki will be smelly, and she won't change
She's
the
right.
Right, yes.
So it could happen anywhere.
Okay, it's
neglect.
it's
לא מתחילה מצחים, אני אומרת לרווחה, זה ממש...
okay.
מישהי מוציאה שבת כזה מהפה כבר, צריכה להיות ברווחה.
נכון, היא לא הייתה מוכרת עד שהיא אמרה לי.
אוקיי, יש הזנחה אחרת באנגליה, אני חושבת, אבל זה בא מאיזה אהבה או משהו, אני יודעת. Okay, I don't want to dwell on this, 'cause I'm sure... Ken?
It's also very rare here not to bring a child to a doctor for such a long period.
Every
Because
week
usually
They come all the time.
children to the doctor quite often, so I don't believe many children will be so neglected for such a long time.
Yeah.
But we see it
I don't know. I mean, I think different patterns of healthcare and health-seeking behaviour. Okay, this is just. I'm sure this is medical student stuff. I think the important thing is, of course, that as what you're all saying, that the non-organic, the issues that really concern families and should concern us, is the psychosocial sort of situation you're describing, where things go wrong, where the baby won't eat, the parents have. There's stress and tension and anxiety around weight and eating. I mean, medically, I tend to divide it into 4. There's the intake problems, such as reflux, cow's milk protein intolerance, repeat viral infections. Very often, children start getting sick and it turns their appetite off. and it becomes a bit of a cycle when the viral infections repeat. Oromotor dysfunction is an important one because mild oromotor dysfunction can really affect how well a child eats. If they just have, if you like, clumsiness of the way of the oromotor muscles, then they're not going to be able to get onto solid foods as well and chew them, and it's solid foods which have more energy dense richness, obviously, than just having fluids. Then you move on to absorption. Celiac disease and cystic fibrosis are the big malabsorption concerns, but infection, giardia, whatever can cause it. Then chronic illnesses. Of course, any chronic illness can affect a child's weight and growth. And what we'd be looking for is some form of chronic infection. There's endocrine concerns, congenital heart disease, tumours. I mean, you know, that's the sort of end of the market, which I don't think we need to be concerning ourselves in too much. Obviously, we need to be able to exclude those. And then on the genetic front, genetic is the wrong word, it's probably congenital. It's somebody mentioned the short parents who have a short child. Intrauterine growth retardation from any cause can have an effect on a child's weight. If they're going to catch up, they catch up early. So if they're born underweight, they're usually caught up to where they should be within 3 or 6 months. Height may take longer. Then, of course, you've got syndromes. But that's really not the focus of what I wanted to talk about today. We obviously need to learn how to recognise when there's a problem and refer on appropriately. What I do want to talk about is, one of you mentioned it now, the definitions, because I don't even know the words in Hebrew, but in England there's been quite a lot of debate about what do we mean by failure to thrive. Should we be using the word failure to thrive? What is failure to thrive in Hebrew? Okay, המילה זה אין כישלון שם. Say it again. Sigsug is thriving. What's failure to thrive? כישלון. אז משתמשים ב-FTT, אני לא יודעת. Okay. That term is really no longer favoured or even used in England because the word failure implies that the mother's failing. It gives a strong message out that, and also that the baby is failing. You don't really want to set this baby up for failure long term. Along with the fact that very often a baby's weight can go down, but it can be completely normal. So to call that failure to thrive is just wrong. So we now use the term weight faltering or growth faltering. Faltering, what's faltering in Hebrew? No, faltering is כמו זה הולך לאט. I don't know, but the important thing is that we don't use the word failure. I'll come through to what the growth patterns that cause concern are, but it's important that we can talk about weight faltering because that's a fact, that the weight is not going as it usually does. What one's very important, I think you've already mentioned this, the catch down growth one needs to check on and not be too worried about when a baby is born bigger than they should be and they catch down to the centile they're meant to be on. And then there's the small babies, which may be of concern, but very often are not. They're just small babies because they're small and they're perfectly healthy. Now, this is the guidance that we use to look about concern. But I think on the whole, that's the border, but it doesn't mean there's pathology beyond it. When a baby actually loses weight, then that's worrying, but usually we know why. They've got diarrhea or they're sick, but actual weight loss is obviously not what children should do. We take a sustained fall through 2 centile spaces as being something that's worth looking at. Once again, I don't want to say that, by any means that every baby who falls down 2 centile spaces that there's really a concern, but the nurse in Tipat Chalav should, and apparently they are, picking up on these children. The question is, what do they do with them? But they should certainly be looking at them and checking things are okay. A baby who's absolutely small, i.e. we have the second centile, you have third centiles here, or you have 2 standard deviations. That someone who's below that, it's important to look at this baby and find out why. It doesn't mean that they're not healthy. A sawtooth pattern can be worrying. If a baby, particularly these are the ones that we're concerned about in social services, is when a baby tends to do this. It implies that they can catch up weight, but then people don't continue focusing on it and it drops off. And this is a sign of possible child neglect. And this last one I don't believe in at all, but it's on our recommendations, that when a baby is 2 centiles lower in weight than they are in height, then that should be worrying. I mean, usually it's just that they're a thin baby from a thin family, and so what? But so those are the definitions. The question is, how do I see the paediatrician's role? Does anybody want to throw out what you think what your role should be or is? We've partly discussed it, and one is obviously to make sure there's no disease process underlying it.
Advices on nutrition and
Okay, nutritional advice, yeah.
Guidance for the family.
So you take it broader, good, yeah, guidance for the family. Yeah, I mean that's, oh, okay, oh, diagnosis is a bit different than ruling out something, okay.
And follow-up, which is maybe the most important. If you give
Yeah, okay, then you want to,
you need to see
I think that's probably straightforward.
that they're using them.
Okay. Yeah, okay. Do you tend to always refer on, or do you tend to, no? Okay,
Depends on the
okay, yeah, we'll come on to that. So, I mean, that's, what I wanted to go into in quite a bit of detail now is the assessment, and I hope it's not too basic, but hopefully it'll be a matter for discussing things. The important thing is that the history needs to be a real in-depth history, focusing on those aspects that we've been talking about, not just on the child, but what is this doing to the family, who is concerned, why they're concerned, what's going on around meal times, and so on. So I've highlighted just a few points here. I think obviously one needs to look into if there are frequent infections. I mean, from any cause, it's not that the infection itself causes the fall off in growth, but just being repeatedly sick is something that we often see, and the baby never gets a chance to catch up. It can also be the trigger for things going wrong around feeding. That when a baby's ill, it obviously arouses anxiety. It means that there's pressure on the baby to eat. If you pressure babies and young children to eat, then usually it backfires and they become resistant to eating. So the response is to push harder, and so you get a real vicious circle, and it very often starts either with one bad infection or a series of infections that cause some weight loss, and then the anxiety fits in. So you could also get food aversion from reflux, and that's something, I think it's a diagnosis that we've only become aware of in the last 10 years or so, but that can really affect, you think it's maybe more? Certainly at the start of my career there was, which was a long time, more than 10 years ago, but there wasn't much awareness. I mean, people were aware of babies vomiting lots, but the idea of having...
I grew up with it.
Okay, and it was recognised.
I remember in the hospital doing כשהתמחיתי, זה היה חלק משהו שתמיד דיברו עליו ותמיד היה ברקע. זה אמרו את זה טוב.
Okay, well anyway, I think milk intolerance is something else that we understand somewhat better than we used to. Lack of calories. I mean, clearly one wants to take a nutritional history, and we'll go through that in a minute. One of the things that's interesting that I've come across a few times is the parents who are very healthy and therefore only have healthy foods. And I think there's little recognition that very young children actually need a lot of calories.
Vegans or vegetarians?
Yeah, certainly vegans. Vegetarians, you know, But vegan, certainly, yeah. The muesli belt, it's called, you know, where there's real avoidance of any fats, and it's very difficult for children to put on adequate weight unless they're eating a certain amount of fat. Another thing to focus on in the history is the sorts of foods, the textures of foods that children are eating. Those children who have oromotor dysfunction will have a great difficulty taking in solid foods and learning to chew. Perhaps the hardest thing of all is food with lumps in it. That is, you can drink solid fluids, you can eat solids, but when the fluid has got lumps in it, it's very difficult, unless you're skilled in eating, to separate the bits that need chewing from just swallowing. So that can be a pointer. And once again, if foods are pushed too soon in babies who aren't ready for them, it can cause distress and avoidance of eating foods. It's amazing how much children can refuse to eat. I don't know how many of us, you know, I think we commonly say if a child is refusing to eat ever, just leave it, you know, they'll turn around and eat in 24 hours or whatever. But extraordinarily, I've seen it time and again, there are children who are so difficult to eat, they just really seem to lack any appetite at all. The parents will tell you that, and it's taken me a while to really take it on board and believe it, if you like. But clearly one wants to know about food refusal. And I think important to find out what the parents think is the cause for a child not eating. What do they put it down to? And very often you will find that there was one episode early on that caused problems, either reflux or a baby choked on food, and ever since then he's been fearful of eating, or a vomiting illness where the child has been turned off eating altogether. It helps to get a whole picture, in part because it helps you know how to handle it, but also I think it increases parents' faith in you as a doctor, that you really understand what's going on and you understand the distress that they're in and where it's come from. So I mean, if you want, you can have these slides will be up on the site later, but this is the sort of aspects of the history that is important to get over and above what one would do on any normal history. So as I've mentioned, the acute illnesses, obviously if there is an underlying medical condition, be aware that the eating difficulties that result from that need treating as much as the illness itself does. I mentioned the oromotor development, nutritional history to see whether inadequate calories are being offered, abuse and neglect, talked about these. Important not to forget to really find out. I mean, I suspect you'll get it, but to explore the sorts of reactions that are going on at home, certainly with the mother, but also around, because no doubt in a problem like this, they're getting advice from neighbours and grandparents and so on. And so if there are mood or mental health difficulties, it's very, very important to know about them and refer on. Attachment difficulties, of course. If there's any reasons why the mother and baby haven't bonded well together. So the classic is if a baby's been in intensive care and the mother's not been able to hold the baby, that there can be a breakdown in the emotional attachment between them. And so exploring that is key, because it's bound to affect the way she feeds the baby. And force feeding, that is really common, I think, where you make a child eat, and that is so unproductive. You may be able to get 1 or 2 teaspoons in, but in the long run, it's just creating, I was going to say a cross to bear, but that's not something you should say in Israel, but it's, it really is counterproductive to make a child eat. And there are certain aspects of the population that I've worked with who, particularly the Pakistani population, where it was very, very common. You hold the child down, you force a bottle in the mouth and make them drink. Feed them while they're asleep at night. It's not the way to solve the problem.
איך את מתייחסת עכשיו להמלצה להתחיל טעימות בגיל 6 חודשים לעומת טעימות בגיל 4 חודשים.
Well, okay. Well, it's changed. Wait a minute. It used to,
6 חודשים טעימות למי שבשל זה חלון עד כפית כל פעם ולא ארוחת טעימות של
יכול להיות, אבל אחיות בטיפת חלב אומרות 6 חודשים.
okay.
זה גרם הרבה בלבול להורים, והורים הבינו בטעות שמגיל 4 חודשים אפשר להחליף ארוחות. והכוונה הייתה שעד גיל 6 חודשים הם לא יקבלו ארוחות של מצקים, אלא רק טעימות. בגלל שההנחיה הזאת הייתה כל כך מבלבלת להורים, החליטו לוותר עליה ולחזור להנחה של 6 חודשים. מי שאתם מתרשמים שההורים יהיו מסוגלים להבין שהכוונה היא לכפית 2 ביום, אפשר להעמיד מגיל 4 חודשים.
Can you ask that question at the end? Yeah. Okay. Remember it. Let's discuss it at the end if we've got time, because I think it is interesting. Okay. This is once again very basic. You want to know about the birth history, particularly the birth weight. If babies are IUGR, they have a different growth pattern and they may not catch up. Preterm, yeah. I mean, they have their own. Absolutely. First of all, you must correct for, obviously you must correct for age, because otherwise you're worrying unnecessarily.
It's not done. That's something really strange, because they correct the developmental checklist,
But not, no, really? Okay. Okay. Even if they don't do it, you should do it. Yeah. It's hugely important, because otherwise you're completely thrown by it. The social history. Okay. What you want to make sure is that you're not only taking a nutritional history, that you understand about meal structures, who eats with the child, how the food is given, and then other issues of the bigger picture in the family about the functioning of the family, if there's violence in the family, and concerns. Family history is important, particularly, obviously, the parental heights, which can give you a clue when a baby seems to be catching down. And developmentally, of course, one needs to know, because children with developmental delays can have eating problems, and the other concern, which I will come to at the end, is how often do children who have eating difficulties and failure to thrive, how often do they have developmental problems because of the failure to thrive? Whatever, one needs to get a handle on that. So that's the history, and I've emphasised how important it is to be a really very full history involving the entire environment of the child. What about the physical examination? I think something that's really important to emphasise. Well, let me just ask you a question first of all. How many of you here have made a pathological diagnosis because of a baby's poor weight gain? And what diagnosis? Baby is sent to you or comes into you with poor weight gain. How often do you find a underlying condition for it? Rarely. Has anybody ever?
At first time, FTT is first time. At young age, later celiac is very common.
Celiac.
Not very common. Not
And have you made the diagnosis because of poor weight gain?
Yeah.
Okay, so that's one.
It's part of the evaluation of
Okay. Is it common, you think?
It's not common, but I think
Of all the babies you see with poor weight gain?
most common organic
Okay,
reason
all right,
is
okay. Giardiasis, okay. Is it common that you pick that up? No, you look for it a lot and it occasionally comes out. It's really interesting, because all the concerns about an underlying condition, it is actually rare. There was a study done, admittedly a while ago, in England by social workers, not by doctors, and they found that 5% of the children with poor weight gain had some unexpected organic cause. It is a lot. I'm surprised that it's that much, and I can't tell you exactly what the definition was of failure to thrive, but 1 in 20 is actually more than I would expect. There's another study done years ago, and I can't even remember where I found this, but they looked at children hospitalised children for failure to thrive. And here's the pie chart of what they found. The interesting thing was that 30% had an organic problem, but only 7% was it occult. So when you take a population of hospitalized children with failure to thrive, only 7%, that's less than 1 in 11 or something, where you find something that isn't obvious. Okay, so I mean, it's a big message, and I think it says it's sort of something that hasn't been transmitted across to families, and perhaps certainly not to nurses in Tipat Chalav, that it's very rare that we should be really concerned that there's a problem. But obviously, as doctors, it's our role to find out those 1 in 20 or whatever. No, not hanacha. No, haznacha. What? Oh, did I? Where are we? Yeah, bishvuz. This is a while ago, and I think now we would look after those children in the community more. Okay, so investigations. This was another study done in America, and he looked at, Richard Sills looked at 185 children admitted to hospital with failure to thrive. 34 of them had an organic cause. So it's all this sort of figures again, that even in hospital, the kids we're most worried about, it's rare to have an organic cause. So there was Sills' study, 185 children. He found 34 with an illness. The important point of this is I want you to think about how did they come to that diagnosis on the 34? And there's 3 options I'm giving you. I'd like you to vote as to whether you think the most useful information in making the diagnosis came from the physical exam, whether it was the history and physical exam combined, almost, well, if you like, how often were the physical exam and history enough to make a diagnosis? And then thirdly, how many do you think that investigations were crucial in making the diagnosis? Kol hakavod. Okay, here's some answers. Okay. The physical exam resulted in only one of the cases was a diagnosis made on the basis of the physical exam. When you combine the history and physical exam together, then all of them, the diagnosis was made. Or we're not saying the diagnosis was made, but it was clear from the history and physical exam that there was an organic cause underlying the failure to thrive. And not in one case were the investigations turning up a diagnosis unless there was already an indication in the history and physical exam. And this is an easy way of looking at it. So the history alone was useful in 17. In only one case did it help to add in the physical exam, or to have the physical exam. Combination was important, and that in no, and you know what it says is, I mean, I'm aware that Israel is a country where investigations are done like that. That
here you heard about the GRD and about the celiac, but here only the lab result helped them diagnose them.
No, I think there must have been, maybe not.
It's not hospitalized.
It's. Yeah, but you've probably got diarrhea. Significant diarrhea, maybe? I mean, you can't be precise. I'm not saying don't do investigations, but I think one needs to be aware that they're not going to turn up something unless there's some indication. Okay, but some messages that I feel are important. First of all, it's hugely important to do a full medical assessment, because whatever we may know about how rare it is that we find a medical cause, it'll be concerning the parents that there's something wrong with this baby. And so doing a thorough physical exam is important to make them feel that you're taking that seriously enough and convincing enough. Obviously, we need to measure height and weight absolutely accurately, and it's often done very badly, even in Tipat Chalav. In terms of investigations, to be honest, I think that the only ones that I feel are really of common help is a blood count and ferritin level, because iron deficiency anemia is so common in that age group and can affect appetite. So I did that very readily. Anything else, I found that I was usually doing more investigations more to reassure the parents that stones were being unturned. But it was important for me to realise that was why I was doing it. It wasn't because it was really going to help me make the diagnosis.
ספירת דם ופריטין. בגלל שמה שאני יצא להתקל שמופנים אליי בני 4 חודשים שפתאום יש...
Oh, that's already, yeah, that's already young. Mostly because I was a specialist clinic, they would be followed in the community for a while, and I would tend to see them a year, 18 months. So that was really important. I agree with you. I wouldn't do it much younger unless there was a, you know, I felt there was a reason to do it.
אני רוצה לספר משהו קצר, סליחה שמפרח, על מקרה שהיה לי במרפאה, שהופלטה אליי תינוקת בת 4 חודשים עם ירידה במשקל ועל עקום אחוזון 3, ודיברנו על הבדיקה, ואני שואלת את האמא, אני עדיין לא מכירה אותה, זה פעם ראשונה, אנמנסה והכל בסדר, וההורים באו עם עוד 2 ילדים ונראים מאוד בסדר, ורק אז היא מוציאה לי את האנמנסה פרפקט, וילדה נולדה, הכל בסדר, שום מעקבים, שום כלום. לא הספקתי אפילו להסתכל בתיק הרפואי לפני שאני מסתכלת להכיר אותה, ואני בודקת אותה, וילדה נראית לי דיסמורפיזם קל שאני אפילו לא יכולה לתת לו שם או משהו כזה, גם האמא לא הכי יפה, אז אמרתי, אני לא יודעת. בדקתי אותה, ואני שומעת לה יבשה. אני אומרת, את יודעת שיש לה יבשה בלב, הסברתי לה מה זה, כן, אנחנו בעצם במעקבים קרדיולוגיים. ואז באיזה עוד מעקבים את שאלתי, ולא סיבת, כן, אנחנו גם במעקב משהו עם הכלבת נפרולוגיה, ואז אמרתי לה, תגידי, יש לה מראה קצת שונה למי היא דומה? כן, אנחנו גם בבירור גנטי. ויש איזו ילדה עם איזה מום לבבי, וכלום, לא השקעתי 10 דקות באנמנזה בהתחלה, כי זו בדיקה, מפנים כל הזמן מטיפת חלב, וגם מאוד לקוני. ירדה מאחוזון כך וכך, למעקב גדילה. ובהבחנה של נונן בכלל, והאימא בכלל בהכחשה מלאה, ובגלל זה היא גם לא מספרת, כי זה יעבור עם הגיל. מסתבר גם שהיא ידעה שבכלל מההיריון עוד, שאמרו לה שיש סיכון לנונן מההיריון, היא הייתה למה מילה חלוטין. בגלל יבשה הכל התחיל.
טוב, אז זה פשוט מה שחשבתי לעשות, אני לא רוצה להתמוקד על זה יותר מדי. Okay, but let's move on to the dietary assessment. את רוצה? מה?
מה זה PV?
plasma viscosity, זה במקום sedimentation. עכשיו לא עושים ESR כל כך. כן. The growth hormone testing. Growth hormone. No, I wasn't thinking for you. This is more referral to an endocrinologist to do a full pituitary workup. You don't do IGF-1 in the community, do you? Yeah? Okay.
מה זה all the time? איזה גיל שאת מתחילה לעשות צילום כף יד לגיל העצמות?
Okay. Okay. I wouldn't do it before the age of 3. I mean, the bones aren't mature enough to do a bone age. Even then, it usually takes longer to get on. It's usually longer, and on the whole, I wouldn't think it would be done in the community. I would assume it would be done by an endocrinologist rather than you. Unless you're talking about primary school age children. Oh, I see. Okay. Okay. Yeah. But certainly it's under the age of 3, certainly not, but probably under the age of 5, rarely. Okay, so the dietary history, the dietary history is crucial. It's a way of finding out how much the child is actually eating. And what you want to know is obviously the amounts actually taken, not what's being presented. Whether the food is being given which is age appropriate, are they still on liquids when they should be on solid foods, or the other way around, is solid food, well, no, not so much solid food being given. It's the routine of the meals is important. How often is it being given? Is it actually given are meal times happening? I'll come on a lot to talk about meal times. Fluids, if children are filled up with fluids, particularly milk, it can take away their appetite. We do it both ways. If they're drinking too much and they're gaining weight poorly, we say it's taken away their appetite. If they're putting on too much weight, we say, it's because of all the milk they're drinking. So we have it both ways. But, and you want to know what's happening overnight, Rob?
Preparation of the formula. Appropriate preparation of formula.
Okay.
I had one case of FTT, which was found half dilution because of constipation.
Okay.
So I said for years, and only once I found that, but parents can prepare the formula in different ways.
Yep. You're saying that the way they prepared the formula caused constipation?
No. They prepared half dilution formula for moms because of constipation.
Okay.
Half dilution.
Okay, so there's two ways of getting Okay. There's two ways of taking a dietary history. One is a 24-hour recall, and the other is doing a diet diary. And I would like to show you both of them. Okay, the way you do a 24-hour recall, it's very important that you go through the day one by one. You don't want to ask, what did they have at breakfast? What did you have at lunch? What did you have at supper? It's important that it's, what did he eat next? What did he eat next? What did he eat next? Because if you just focus on the meal times, you won't get the in-between stuff, and you won't get a sense of the pattern of the meal times. You want to roughly know what sort of quantities were eaten. Important to know also what foods were offered but weren't eaten. And generally it's better to ask open questions about, what did the child eat next, or rather than did the child have breakfast, of which the answer is yes or no. So really let them talk you through the day and make sure that it's the whole day is open so that they can take. And very often, I hate it, sometimes you hear professionals talking about parents lying to you. And I guess there's two reasons why they lie, but mainly it's out of anxiety. They want to prove to you that however much they try and give, the child's not gaining weight. And very often, at least because of the worry about child abuse and neglect in England, I think professionals sometimes think that parents are saying that they're giving more than they have, or making up the way that the child eats. But it feels like this is less of an issue here in this country. Okay, here's an example. Mason's 3 years old. He's showing weight faltering and also has constipation. You take a 24-hour recall, and I'm going to show you the diet. And I'd like you to think about 3 things you can suggest to his mother which might help him gain weight.
How old is he?
3 years old. What do you think of this? Yeah, crisps are the English word for French, not for chips. Yeah. He's giving a lot of milk products. Yeah. A lot of milk. There's a lot of milk, and on top of that, there's yogurt. Yeah. Do you think that's a problem? How often do we expect children at the age of 3 to eat? Okay. Yeah, I mean, the rule of thumb is 3 meals and 2 snacks at that age. With babies, 3 meals and 3 snacks. But do you call the...
If he ate at 12, he ate pasta, why does he eat sausage at 2:30?
Okay.
And then at 3 o'clock, milk again.
So what would one recommend to her?
Again, and organize the daily menu.
To give him some breakfast in the morning.
Okay, breakfast in the morning is a good idea. Okay. Just a cup of milk. Let's have breakfast before you go to nursery. Okay.
And then to cut the 2:30 meal and change the 3 o'clock meal to something more healthy than cup of milk.
Okay.
Some sort of fruit or piece of bread.
Absolutely.
And then to give him some dinner or supper, whatever he calls it.
Yeah.
He also has a lot of protein and fat.
There's a lot of gluten and no fat. Sausage rolls. The sausage roll has got fat in it. It's all in pastry. I don't know. I don't know. You need to take this. This is probably a standard diet for. Okay, so what was suggested? First of all, to improve the routine. I mean, I don't know whether you picked up, but that he actually ate on the way to nursery and on the way back home. It wasn't like a sit-down meal. So better routines than you've got starting the day with breakfast. Something we don't know, but we would want to ask about is who does this child eat with? Is he eating on his own? Or is it a family type meal? Because on the whole, children eat much better when they're eating socially. And one of the key major therapeutic things we did would be to suggest that the child goes to gun, which they wouldn't necessarily in England, because there, if it's a problematic eater, when they're sitting, they're like puppies, you know, when they sit down together and eat with other children, they may often eat better than they would do at home. The other thing about gun is that they're probably going to be fed by somebody who doesn't care very much whether they eat or not. So there's no anxiety, and they often will eat better there. It's a very hard thing for the parents to take, but that's the... Okay, and we talked about increasing the variety. You mentioned, nobody mentioned fibre, but the fluids and fibres, we didn't focus on his constipation, but that would help his constipation. Okay, what about diet diaries? Okay, so Amina, this is child. She's got faltering weight gain. Her mother filled in this diet diary. First of all, my first question is, how old do you think this child is?
We can't see anything else.
You can't see. So how old do you think this child is from what you can see? How old? Give me an age. Maximum age.
8 months.
8 months.
Probably 18 months.
No, she has 2 eggs here. So she's more than 4 months maybe. 1 year.
1 year you'll go for. She's actually 2 years old, and I blocked out the date the diary was taken. She's 2 years old. So this already, you know, you see this child, if you haven't taken a detailed dietary history, you wouldn't pick up about how inappropriate this meal is. Any comments about the other food that she's eating? It could be either. At 2 years of age, it doesn't matter. Oh, I see. What did she mean? I don't know. I can't remember. But it's a good question. No, because you often do. When parents are worried, they think that formula has better food in it for more nutrition than ordinary milk. So they may keep giving it, and it's expensive. There's no point.
Usually what I see in the clinic, there are children that don't eat well. At the time of 18 months old, you see a child that's still eating about 4 a day. Not milk, usually formula.
Right.
The parents will tell you milk.
And anything else you want to comment about this? Okay, we'll go on. Okay, so she's actually over 2 years of age. Okay, what we found out when we discussed the food diary with her, we found out more. First of all, she feeds Amina on the sofa or floor, which isn't if you've got a problematic, I mean, I don't want to be judgmental about feeding children, but I do believe that sitting at a table or in a high chair is actually much more productive. But if you've got a child who's a worrying eater, then and we'll see some pictures soon, you're asking for trouble feeding them on the sofa or floor because they'll just escape. She doesn't eat. She's 2 years old, but she doesn't eat with other people. Okay, the siblings are at school, her mother eats and father eats differently, so she's always being fed on her own. And you know, this is clearly one way. Remember, this is a child who's not gaining weight well. She goes to bed at 11 and wakes just prior to school at 8:30. That's very late, which is something perhaps that, well, I don't know, this is cultural, but in England children go to bed at 7:30. So 11 o'clock is something that we would want to tackle. And she has a long sleep in the afternoon, probably because she's got so little sleep at night, which means there's less opportunity for her to eat during the day. So, The sorts of thing that were recommended was to allow her to touch and handle food, which at the age of 2, if she's never done that, may be something that will be difficult for her. She may not immediately go for it, and it may take some working to do it, and offer her finger foods, which we didn't comment on, but really all she was getting was either spoon feeding or drinking milk at the age of 2, when she should have been able to eat with a spoon and fork. She was only having 2 meals a day, so she was missing, once again, breakfast was being missed. So you want to work towards having meals and snacks. I mentioned the sleeping for a long period in the afternoon. And we could pick up on that from the food diary. Probably we wouldn't have thought of asking how long does the child sleep, but because there was such a long gap in eating, and why didn't you think of feeding her then, it emerged that her whole routine was not ideal. Very difficult thing to do. Recommend cutting down on milk with the idea that the appetite will increase, but of course for a child who's only surviving on milk, it's very hard for families to actually cut back on the only nutrition they're having. But really to try and encourage textures and varieties. And you asked about the solid food coming in at 4 months, 6 months. A lot of it is about getting children to accept foods of different textures and flavours early enough at a critical period. And so it may be harder for her to pick up on new sorts of food, given that she's really only survived on milk for 2 years.
Because she refused to take anything else? Or
You know, to be honest, I cannot remember at this stage. I took this from my colleague, this particular example. And so I think it was probably, her name is Amina, or the changed name is Amina, so she's likely to come from the Pakistani population. And there they very much focus on milk, very exclusively. And they always wean onto milk foods as well, Daisa and so on, for a long time. So my guess is it was just cultural, rather than that she was a real food refuser. But I can't, hand on heart, tell you that. Here's another one, just really illustrating the same sort of thing. You can't read it, okay. Well, you don't have to read it. You can see that here's the morning, okay. So she starts with Weetabix, which is one of these healthy foods that gives them no calories, but fills them up, and then doesn't eat anything right until here. There's no, here's a bottle of juice and a cup of black currant juice. So she's getting proper food here, but there's a long gap between the two. And once again, this has got a small packet of white chocolate buttons, but she's not really eating again until just before she goes to bed, and then that's it. So she's only getting 3 meals. And if you're worried about a child and you want them to eat more, most children need to eat more often than 3 times a day. So is there any questions? I'll come on about the advice again, but about doing a food diary or doing a 24-hour recall.
לי שאלה, הערה, כשאני מנסה לשחזר עם הורים ב-24 שעות בריקול, זה לא שהורים רוצים לשקר, אבל הם באמת שוכחים.
כן.
אז אמא אמרה לי, אני לא זוכרת מה לבשתי כשבאתי לפה, אז לזכור מה היא אכלה בבוקר. אז אני מוצאת את זה שיטה פחות טובה ומתסכלת, ולבקש מהם לרשום יומן באמת, זה יותר פרודוקטיבי.
אוקיי.
מה שאני עושה, אני מבקשת מהם, קובעת להם פגישה נוספת פעם אחרת עם יותר זמן, ואומרת להם להביא מהבית רשימה של 3 ימים מה הם אכלו.
Okay, that's a food diary. בדיוק אותו דבר. Yeah, okay. That is the better way of doing it. It's just often it can be harder to do because you have to meet them again immediately afterwards. You have more luxury because you're working in primary care. With us, we didn't see children that frequently. It was something special to bring them back. But there's no question that a diary is better than a 24-hour recall, provided the family want to do it and they invest in it. And you get a lot more from it. Because you can also ask them who do they eat with and so on. Okay, something I want to introduce you to, which is, it sounds like this isn't within your capacity to actually do mealtime observations, unless you're lucky enough to have somebody who can do it for you. But nonetheless, I think there are real lessons to be learned from it. There's so much one learns about a family from going to the home and actually watching a child eat. Some places bring the child, ask the family to bring the food the child eats and actually feed them in front of them, and that can be useful. But it's no substitute for going to the home and really understanding on what's going on. Okay. And I'm not going to dwell on watching a mealtime because we're all going to watch a mealtime, 7 mealtimes after we've had a break. But what I'd like to do now is to move on to the questions about what can we do. The principal interventions are, and I've put them, I think, in order of what I think are important. The first is meal times, not so much what the child is eating, but how they're eating. And I've got a handout somewhere. I think Karen's got it somewhere. You want to make sure they're eating regularly, but also socially, that they're given every opportunity to feed themselves. Very different when a child has the autonomy and independence to eat themselves. So as soon as they're able to developmentally be able to handle foods, and of course that's 7 months, they should be able to grab something and eat it, that they should be given the opportunity. And so often what happens is that parents, because of their anxiety, or maybe just culturally, they want the control of giving the child food. And that's... Yeah, except the thing is not to forget that the child should have some independence in eating. And that meal times should be good times where there's... Yeah, and that it's a social event where people are enjoying the food and there isn't pressure and stress. Certainly, emotional behavioural issues have got to be taken on, and they almost... well, okay, that's important. Nutrition, we've talked about a bit, and as I say, I've got some actual guidance on that. But then not to forget the wider social picture about what's going on, because that will certainly be influencing what's happening with the child. So here's 2 slides, and there is a handout. Do you know? You don't know where? Okay, so after the break, I'll give it in. What were our principles? The first was that children basically need calories to grow. People worry a lot about protein, but actually it's the calories that really count. So if you're worried about a child's weight, try and get more calories in. And the easiest way to get more calories in is fat, because fat is very dense in calories. And so you can get around it for those picky eaters by putting butter in the puree or well, I leave it to your imagination, but just trying to sneak extra calories in. Next is, we've already discussed that children need to have more than 3 meals a day. They need snacks, and you can increase the number of snacks. What I would say, though, is that if you're having snacks, what is not great is when children are chased around the room having snacks the whole time, that each mealtime, for me it's important that if a child is eating, then make sure that they're sitting down, they're eating in company, and somebody else is having a drink with them. But don't drive them crazy trying to feed them right throughout the day, or leave food around for them to eat. Try and build in structure and routine. If you're worried about the weight, then the child shouldn't go for more, except overnight, but shouldn't go for more than a few hours without being offered food. Fluids. Don't discourage constant drinking. I mean, it's very common in England for children to wander around at the age of 2 or 3 with a bottle, just drinking either milk or juice, or worse, tea with sugar in it. But cutting back on fluids can help increase an appetite for solid foods. And lastly, a dummy is the English word for mozzets, but reducing that can be helpful, because it can actually affect appetite, or taking the mozzets away can increase appetite.
Question, what about very young children, under a year? Because they have different diet, they're not...
Yeah.
Most of them don't eat solids as well as 2-year-olds.
Okay.
And if you want to, sometimes a mother comes in at 6 months with the baby, there is a problem with weight gain. What would you suggest then? To add to, usually they eat formula and a little bit of solid foods.
Well, from 6 months, I would already be, I mean, that's really starting solid foods, but make sure that the solid foods being given aren't, or less vegetables like courgettes and more sweet potatoes, things with calories in it.
Concentrate the formula, sometimes we hear dietitians adding the corn flour to the formula.
That was not an approach we would ever take. What we believe, I mean, the underlying belief was that you could manage these children by improving the quality or richness of the natural diet. So dietitians a lot in England use these supplements, which we use very rarely. Not corn flour, but can't think of the name of them. Energy supplements.
Polycose.
Something like Polycose, yes, which we really didn't encourage using. That it was more to say that this is, if you like, a natural sort of condition, and that we have ordinary foods that can be as enriching as using.
Very, very young child, like 4 months old.
Few months.
Yeah, then it depends on what the cause was, and we certainly prescribed it on occasion, but it was more increasing the frequency and encouraging more volumes. You'll see from the videos in a moment.
Excuse me. לעלות, לתת להם כמויות גדולות ולהתאים יותר קריבות. זה מה שאני מבין.
That's the message.
אבל לא להוסיף שום דבר אחר, חוץ מהחלב.
לתינוקות קטנות ועוד אוכל מוצק.
כל משהו תוסף אחר לא להוסיף. אין, לא מומלץ?
לא בתוך הבקבוק, לא.
אני מדבר על ילדים בגיל מספר...
אני מבינה, אבל לא שמנו עוד דברים בתוך בקבוק.
והם לא עולים במשקל, הם מקבלים כמויות יותר גדולות ולעתים יותר גדולות ולא עולים במשקל. מה מציעים להם?
Well, occasionally we would use Polycose. I'd want to know why that was happening.
ילד חולה קרדיאק, שיש לו בעיה לב, צריך לעלות אותו במשקל.
זה משהו אחר.
צריך לעלות אותו במשקל, אז מה עושים?
Then you do add Polycose in, something like that. Yeah. I'm talking more about healthy children that's just showing weight faltering.
היו לי כמה ילדים מאוד בעייתיים בתזונה, והם התגייסו לצבא, והתחילו לאכול פנטסטי.
כן?
למה? כי הם קיבלו ארוחות מסודרות, בלי small snacks בין ארוחות.
אוקיי. אבל הם בני 18.
חצי שעה.
כן. אוקיי.
והם התחילו לאכול ירקות, בשר, הכל. וגם ילדים קטנים אני אומר, מגיל 0 צריך ככה.
No, I agree with you. It's routines, it's set times to meal times, lots of physical activity. And, okay. So what about focusing on the meal time itself? So we've nearly got to the break. So try to provide a relaxed, calm atmosphere. You know something, I'm going to come to that later. Let's go on. There was a question about referring on. The when is difficult unless you bring specific examples. But I think the key thing is that if there's a specialist team, it's their working together with the most complex cases that they're needed. On the whole, they are not needed. I think there's so much that can be done, and time itself can play it out. But if it's complex or very long-standing weight concerns, then clearly a specialist team needs to come in. We used to, I don't know how much you do that, the nurses refer to us, but then there are nurses who are excellent at giving dietary advice and support and being able to see them more frequently than perhaps doctors can. And so we would refer back to the nurses in Tipat Chalav, and also particularly if we wanted to have somebody go into the home and watch a mealtime and give real-time advice to the mother. Dietitian, if you're really concerned about the quality of the diet rather than only the pattern of eating. A speech and language therapist, if you're concerned, if the child is really not taking solid foods at the stage that you would expect them to, then a speech therapist. And of course, if there's also accompanying language, speech difficulties. Sounds like here in Israel you don't need to refer to social workers because there's no worries about neglect and abuse, but we referred to them very regularly. And then we referred to a gun if for children who aren't in some sort of ma'arechet, because for the reasons you said about going to the army, that when children sit down and eat together, fed by somebody who doesn't care so much about them, and with other children eating, it can make quite a big difference. I just want to end up here with going on to thinking about the long-term outcomes. And I told you I did a systematic review looking at the long-term outcomes. And the systematic review was actually triggered by this real letter, which you obviously can't read, but I'll read it to you. At that point, there was guidance that any child who dropped down 2 centiles or who was underneath the 3rd centile should be referred to a paediatrician to be checked. Okay, we don't have primary care paediatrics, we only have family doctors. And so that was the rule. And I got this letter which took away my breath because it's quite an aggressive letter. Dear Dr. Rudolph, as you can see from the centile charts, from the growth charts, this child started life above the 90th centile and is now below the 2nd for no apparent reason. She seems to be a healthy child. Mum is not worried. Nevertheless, the protocols that rule our lives these days indicate that I should refer her to you at Community Paediatrics and leave it to you to decide whether you wish to see her or not. So here was a real question, and I had sympathy with it. This was a big baby who dropped down. Why couldn't the family doctor just reassure the parent? That was one thing that happened. But then something shortly afterwards happened to me, that I saw a child who had weight faltering or failure to thrive and had seen a paediatrician in the hospital, the other hospital across the city. And the family were told that unless they got this child to eat, that he would suffer from brain damage. And they were clearly beside themselves. They were actually members of the Reform synagogue, and they spoke to somebody who said, why don't they come and see me? And they told me this story, and you can imagine they were completely beside themselves with anxiety. And I looked at this child who was verbal, his language was ahead of his age, he was short, he was thin, he was playing well, he was interacting well with the family, and I thought, how could anybody think that this child, actually I think he was almost 3 by the time I saw him, was suffering from brain damage because he wasn't growing well? And those 2 things made me think, I've got to know what is the prognosis for these children. All through this talk, all through this time I've been working with these sorts of babies, the question is, how much damage do we do by weighing babies and young children so frequently? The nurses in Tipat Halava jump up and refer in. The families are all anxious about it. And for the most part, what we're seeing is healthy children who've got eating difficulties, but where it doesn't seem as if, certainly there isn't a medical cause for it, nor do they probably suffer damage. So I went out to the literature to really try and find the answer. So that was my question. I wanted to know the outcome of children diagnosed with failure to thrive in terms of growth, development, and behaviour. And so I and a colleague looked for all the cohort studies of children that we could find where a diagnosis of failure to thrive had been made. But we needed to have a control group. It was clearly no point just having cohorts of clinic children being followed without any sort of matched control to know what the population, what those children would turn out like if they hadn't been followed. We actually only found 5 studies. There were a lot of reports of failure to thrive, and a lot of them showing very worrying things, because of course some babies who fail to thrive have got significant congenital abnormalities or major illnesses. But there were 5 studies that were identified which were of adequate quality and where there was a control group. And it's a long time ago since I did it. It was 2 or 3 of them were population-based. Okay, so most studies, it's somebody who's interested in failure to thrive, follows their children out over time. Some studies were population-based. They went and they checked all the Tipat Chalav records and found children who failed to thrive and then followed them up later. And what we found at the end, the overall summaries were that yes, children who failed to thrive were shorter and lighter than the control group, but they were in the normal range. It's a big message, because when most wouldn't, it wasn't clear because it was an epidemiological study. So yes, they may have been, I don't know quite what treated means exactly. They probably were referred, but as we all know, that a lot of the help that is given isn't terribly effective. But so by the age of 6, there were height and weight differences. It's about the difference of 4 or 5 centimetres or 2.5 kilograms in weight at the age of 6, but they were in the normal range. And what I can say is that mostly the studies did not correct for the parents' height, but when they did, it was just the mother's height, because fathers disappear in England, but that's not present. But when they corrected for mother's height, that difference was much, much smaller. So what we're saying that these children, for the most part, are going to turn out normal. They might be a bit shorter than you would expect from their growth potential, but probably not. In terms of intellect, yeah?
Even in those small differences, you didn't show that intervention may change the course.
This study didn't aim to show the difference in that. The study, I mean, there's other things that you need randomized controlled trials, of course, to see whether, and that comes back to my first study, to really show what the difference is. And there's an issue there because it's not ethical not to treat at all.
Small at the beginning of the process because it reached evaluation. So this small, it's not small.
Yeah. Okay. It's very difficult to unpick this. And in fact, I mean, I think our own study is one of the few where we tried, and we didn't say no treatment. We said one was follow-up with me in the clinic, and one was with a home visitor. And the growth showed no difference there. The eating difficulties resolved, but the growth, they both did well, actually. Most children do show some sort of catch-up. IQ, there's a 3 IQ point difference. That is really trivial on an individual basis. And there didn't seem to be an increase in problems at the age of 7, and then one study went out to the age of 12. So what we're saying is, now, it depends how you define failure to thrive, but for the most part, these babies and children do well. If you can hold it, if you can reduce the anxiety, if you can encourage more normal sorts of eating behaviors. Exactly. If we overly focus, if we over-medicalise the problem, we're doing more harm. I think most of what we see out in primary care is iatrogenic. Well, it's not only iatrogenic because it's culture as well, that society is saying to these mothers, you've got a problem here. But nonetheless, if we can change our tack so that we're more supportive and less medicalising, and we talk about this sort of thing, then it can really help turn things around. But just to end, I suppose one should say that, of course, that failure to thrive can be a marker for really severe things happening. There are those children who've got congenital abnormalities who are destined to be short and to be thin, but they're going to be clear on a decent physical exam and history. You're going to pick them up. You know that those funny-looking kids may very well have a serious problem underlying it. But for those children who are short, who are not gaining weight as well as they should, we should be very much reassuring and attempting to address the parental anxiety and their eating difficulties, because the eating difficulties can be problematic all the way through. And I think there's a lot of soldiers probably who have eating difficulties, even though you say they will end up eating well. So we can do them a good service by trying to encourage good eating. Yeah. מה? סמית נפל לי? לא שמעתי. Okay, I think I want to end there. I think we should have a break. And I think we should come back and look at some videos and growth charts and look at them, okay? Okay, good.